Good afternoon, everyone, and thanks for joining us for today's Healthline. I am Johnette Magner, and we're going to focus on ways that you can live a healthier and happier, as well as a pain-free life. We're going to be taking your calls and answering your questions live in studio. Today, we'll be opening the phone lines, and as a reminder, we want to make sure that you are in a quiet place when you call, and it's important, too, that you have your TV turned down. Our number is 318-219-4569. And joining me today, we're going to talk about shoulder pain, is Dr. Mark Callanan with Willis Knighton Orthopedics. Welcome, we're glad to have you.
Happy to be back. All's good.
All right, so tell me a little bit about what you do at Willis Knighton. What is your...
Absolutely. So I'm an orthopedic surgeon. My designation is sports medicine as a specialty. What sports medicine means, it's again, it sometimes can be a little bit of a misnomer. Yes, we have a lot of high school athletes and younger patients, but at the same token, my stretch of population goes to, I have some centurions in my practice all the way down to teenagers. So it's really kind of the management of, in my case, shoulder, elbow, and knee pains. And that can be everything from ligament reconstructions to cartilage work to, in the shoulder, rotator cuff repairs, all the way up to like shoulder replacements. So we do kind of a broad variety of things on a broad variety of folks, not just, athletes.
So how common is shoulder pain and shoulder problems, and what are the most common causes of them as well?
Absolutely. I would say that probably half my practice is shoulder pain, people coming in, and again, it really depends on the age of the patient coming in, and that's where I can kind of hone in on the most likely pathology, what's going on. In my adult populations, very common, people have shoulder pain, and I would say, kind of designating a traumatic pain versus like what we call an insidious onset of pain, meaning you have some people that are like, I was picking up some boxes, moving some furniture, felt a pop in the shoulder. That's one thing. Or I slipped and fell down the stairs, I landed on the shoulder. That's one thing. Then I have, probably more than half the patients that come in and they're like, look, I thought I slept on this thing wrong. I woke up one morning, the shoulder was hurting me. Fast forward a couple months, it's not getting better, and they're sitting in my clinic telling me about it. In those cases, the large majority are going to be either rotator cuff and or biceps issues, all right? And I bring a little shoulder model simply because sometimes it's a little bit easier to kind of explain, and this is what I like to do in clinic because, instead of hand waving and trying to, show things, I can really kind of correlate exactly on my exam what we're doing on a different model. So to take a step back, when people think about what's the rotator cuff, this, just to orient you, this would be your arm bone. This is the ball and socket joint here. This is your collarbone coming over and your shoulder blade here. The rotator cuff are actually four muscles that attach from the shoulder blade. They reach over and they attach on the outside all the way up to the front side of the shoulder, and they kind of facilitate the reach and grab and pushing, pulling, all the daily activities with the shoulder. They essentially keep the ball centered on the socket. They give some strength and some power. So when people end up with a rotator cuff tear, when people say I tore my cuff, most of the time they're talking about some of the tendons up on the top side of the shoulder. They can tear for a variety of reasons. Over time, just from age and the wear and tear of living life, statistically, almost everybody will develop some degree of a rotator cuff tear, whether or not it's symptomatic and causes pain or not. There's actually been some large population MRI studies where they just took all comers, a big group of people kind of at 65 and up and 70 and up, and said, look, whether or not you have shoulder pain, let's get an MRI, let's see if there's any tears there. In the 70 and up population, I think it was almost 50% of them had some degree of a tear, and some of these people didn't even have shoulder pain. So it is part of that natural just wear and tear process of living life. At the same token, if you think about some people having just normal wear and tear, it doesn't have to be necessarily an injury, but it can also be a volume of activity. I get a lot of people, especially in the spring, where they come in and I'm saying, well, what have you been up to lately? Well, now it's time to start landscaping the yard. They get out there, they're doing the flower beds all day, they're doing mulching, they're doing all this stuff, and it's just an overuse. They start doing it, or they go outside, the weather's nice, they start doing, golf back to back days, or whatever activity you like to do, start playing catch with the kids. All those things can actually lead to development of shoulder pain, not just, I slipped and fell or picked up something heavy. Sometimes it's none of the above. You can sleep on it wrong. It's just the natural wear and tear of the shoulder. You get to a certain point where the body's saying, hey, we were compensating, we were doing okay with this, but now we're kind of at the point where it's starting to become problematic, and that's when people start developing that shoulder pain. So there's really not a set specific incidence of what I see. It's really a broad spectrum of complaints of how it starts and what they were or weren't doing at the time.
So let's talk about evaluating that pain. How do you, at what point do you say, all right, I have given it a few days and it's not getting any better? I would assume people shouldn't run to you the first day necessarily
absolutely.
if they've been doing yard work.
Absolutely.
So kind of give us an idea of when it's time to pick up the phone and give somebody a call.
Yeah, absolutely. That's a great question, because that's where a lot of people wonder. Obviously with the surgery side of things, when they say orthopedic surgeon, most people are like, look, I'm not looking for to be cut on. And that's totally reasonable. If I can get somebody better without cutting them, that's always the goal. So just, to give some peace of mind for patients, coming into an office does not mean we're looking just to sign you up for surgery. So to your point about when do you even need to get referred to a shoulder specialist or an orthopedist, most people, I tell them to give it at least a couple weeks, where if it's something that's new, it hasn't been a recurrent issue for them, they can kind of manage with it. Try to give it a couple weeks, do some anti-inflammatories if they can take them, your standard ibuprofen, Motrin, whatever your preference, some Tylenol. Try to limit the activities where they're doing a lot of repetitive lifting, try to stay off the gardening for a couple days if you can, or whatever it may be. And then, if you have a couple weeks go by where conservative treatment, kind of modifying your activity, trying some over-the-counter anti-inflammatories and medications, icing the shoulder, different modalities aren't working, then it's time to, at least contact your primary care provider. The primary care provider, your internal medicine doctors, some of them have comfort levels where they can do injections, they can prescribe prescription anti-inflammatories, some physical therapy, because these are all kind of the initial three. When patients come to see me, I tell them the big three options we have for conservative treatments in the shoulder are simply that: anti-inflammatories if they can take them, steroid injection, and then physical therapy. So most people coming into my office, they get referred because they've usually had months of pain, they've gone to see the primary care doc, they've had some level of treatment, and they're just not getting better. And that's usually where, if you've had several weeks and it's interfering with your quality of sleep, your day-to-day functions, and it's just not improving, that's certainly a time to get evaluated and come in and see us.
All right, well, we want to tell everyone that the phone lines are open right now. It's 318-219-4569. So we hope that you will pick up the phone, give us a call, and talk to Dr. Callanan about whatever shoulder issue that you are having. When I think about the shoulder, I think about it's right. Everybody's got this pain here, and it's right close to the neck. Do people often think they have a neck problem when it's a shoulder, or a shoulder when it's
or vice versa?
Or
Yeah, absolutely. That's a great question, and there is a lot of overlap between the cervical spine and the shoulder. So a lot of the differentiation tends to be where people feel the pain. When people feel some degree of radiating pain, the shoulder will always kind of radiate down the lateral side of the arm. In fact, people will come in sometimes with a rotator cuff tear or tendonitis and say, "Doc, it's not my shoulder, it's my arm." And that's the classic referral pattern. That's where the body's going to perceive that pain down the side. Now, if it's crossing down past the elbow, it's coming down into the hand where they're getting it all the way down to the fingers, then I start thinking more it's a nerve root. It's certainly something coming more from the neck. When you pointed to exactly here, this is the trapezius, and you also have what we call the pericervical muscles. These also can get tight and be something that's a little bit different outside the shoulder. Now, when people have shoulder pains, some of that development of pain in the trapezius and the neck is secondary to kind of abnormal movement patterns to try to compensate for the shoulder pain. They shrug a little bit more subconsciously. The body tries to do different things because normal motion hurts so much, and then they develop these secondary problems. So that's all kind of part of when we're treating them. If you think about the therapy side, how they're trying to break things down and make people feel better, well, a lot of it is correcting abnormal movement patterns, working on strengthening, doing some soft tissue work, and that's really where the money is with physical therapy with some of these things.
All right, well, we have a caller right now. Cheryl, welcome to the program. Please ask Dr. Callanan your question.
I've had wrist pain since mid-March when I had COVID. It was in both shoulders and both wrists. Well, now it's in my right wrist. I had an x-ray, and they said it was major arthritis, but the blood vessels are really protruding right there up to my mid-arm. Would arthritis make the blood vessels really tight?
Not necessarily. There's probably a lot of things that can contribute to the vascularity around there. Certainly arthritis can cause a lot of that wrist pain, and whether or not that's tied to your COVID shot, and an inflammatory response in the body, it'd be hard to say, especially if you have an x-ray that shows, some advanced arthritis. But I don't think one is necessarily correlated to the other one.
Should I have an ultrasound or something of the vessels, or
You
Further
certainly
testing?
can. An ultrasound would be if somebody's worried about like a clot or an aneurysm or something like that. If you are worried about, an abnormal appearance where on that wrist in particular compared to the opposite side, you think the blood vessels look abnormal or different to you, you can do some vascular studies. If anything, they can tell you, hey, there's no clot, there's no aneurysm or anything abnormal with the vasculature. I don't think that's the wrong answer.
Okay, I was just concerned about the blood vessels.
Yeah. And I don't know if they're necessarily related, but you can always kind of work that up independently as well.
Okay, well, thank you.
All right, thank you for calling in, Cheryl. All right, so you are an orthopedic surgeon specializing in sports medicine. What types of conditions do you see with your athletes coming in?
Absolutely. So my younger populations, obviously I do knees, elbows, and shoulders, and you could talk for hours on each of the kind of individual joints. Specifically with the shoulder, and we were just talking kind of in between things about baseball, ramping back up right now. In my younger athletes, in the real younger adolescent kind of teenage population before they're skeletally mature, I do see some growth plate kind of tractional issues where the growth plates aren't fully fused, so that's kind of a weak point within the bone. So if you take an athlete as he's starting to hit that growth spurt, he or she, their arms get longer, their muscles get stronger, and the amount of torque that they can generate across those bones and those growth plates is more than they've ever seen. So sometimes you get some what we call physeal injuries where you just get some strain across that growth plate. That's like a little leaguer's shoulder or elbow. That's just an overuse thing where we can rest it, anti-inflammatories, all the above. Other things that I see more in the younger populations are like dislocations, people falling, landing, diving for a ball, or just playing and dislocating the shoulder. And shoulder instability is a big problem in my younger athletes in particular. When it comes to shoulder instability, when you're thinking about structures in the shoulder, their rotator cuff tendons are so robust at that age, it's rare in a teenager or a young adult to actually see a rotator cuff tear. They can get tendinitis and strains and all the above. Most of the time, it's going to be a structure called the labrum, which is, if you're thinking of the shoulder joint like a golf ball sitting on a golf tee, the labrum is essentially a little rim of tissue that you can't see on this model. It's almost like putting a rubber O-ring on that golf tee. It kind of deepens things, gives some inherent stability. When you dislocate, you disrupt some of that labrum and some of those tissues around there that give stability and kind of stretch the shoulder out. And so that's where people can develop recurrent problems if you don't treat it correctly the first time with, rest, physical therapy, trying all the above. Even still, the younger you are when you dislocate, the higher percentage you may have it again and may eventually need surgical stabilization. So those are kind of the more common things that I would see in the younger populations as far as the shoulder goes.
All right, well, we have another caller. Debbie, welcome to the program. What is your question for our doctor?
Could you speak more about, I think they're called calcium? I had previous surgery where the calcium formed a knot or whatever and ripped the rotator cuff.
Yeah, absolutely.
And afterwards, or before I finished PT from the surgery, it grew back.
Yes. So, you're talking about calcific tendinitis is what we call it, where some people, their body's response when they have any type of inflammation, specifically in like the rotator cuff tendon, or you develop a little tear, the body's response can actually be to lay down some calcium within the tendon itself. Now this is problematic because that nidus of calcium can actually be quite large, where you can see it on an x-ray sometimes. So even though you can't see the tendons that you typically need an MRI for, sometimes we see a little halo of calcium and I can already tell that you have some calcific tendinitis. Some of it, especially in your case with it recurring, some people are just prone for it and we don't exactly know why. Some certain patients have a physiology that they do tend to lay down calcium inside an injured tendon like that. It can be very painful and cause recurrent inflammation, and certainly it can take up a large portion of that tendon, where if you go in there and do what's called a barbotage, sometimes there's a big hole in the tendon and we actually have to put some anchors in and repair it, which sounds like was the case for you. And unfortunately, even despite all that, some people can lay down that calcium again. Trying the injections, the anti-inflammatories, different things to try to mitigate inflammation in that area to try to get you by without another surgery is usually what we always try. But sometimes you do have to go in and do a repeat debridement if there's more calcium buildup within the shoulder.
Can I ask another question close to that?
You certainly may. Go right ahead.
I found out I have calcification in the bicep tendon. And I'm doing PT and icing and that. Does that the only thing one can do?
Not necessarily, and I'm glad you brought that up. When we talk about rotator cuff being a common thing, the biceps tendon in the shoulder, in particular the one you're talking about, is called the long head of the biceps. And it comes up along the front of the shoulder, does a 90-degree turn around the head, and actually attaches at the top of the socket. That biceps tendon tends to get inflamed whenever somebody has rotator cuff inflammation as well. You can get some calcium deposits within that little bicipital groove, as we call it, right around the tendon. That in and of itself can be painful as well. You can actually do what's called a tenodesis, where you take down that biceps tendon, get rid of the diseased portion, and anchor it down a little bit further in the shoulder and take out some of the calcium deposits with like an open debridement, and tenodesis is certainly a surgical treatment. But I do think that trying to do the injections, the physical therapy, the anti-inflammatories is always kind of our first line of attack on that. But there are surgical options if it was something where it's still really bothering you and you do have those calcium deposits within the biceps.
Okay, thank you for your time. I appreciate it.
Absolutely.
You answered a lot of my questions.
All right, happy to help.
Thank you for calling in, and you all got very specific there. That was, that was, I know, very helpful to her.
No, I know.
Can you, if someone has dislocated their shoulder, can you, Johnette, look at it and say, ooh, it's dislocated? Or is that something that only a doctor can really tell you? Or is it just obvious?
Yeah, that's a good question. It's not always obvious, and some of it depends on the body habitus of the patient. Obviously, the bigger they are, the more soft tissue around that shoulder. Sometimes it can be hard to really tell, is there an abnormality within the shoulder? If you have a thin person, they pop it out. Usually it's pretty obvious. That shoulder looks like it's dipping down. There's kind of a crater around the muscle. You can sometimes even see it kind of perched. Most of them, in fact, probably 90% of them will dislocate out the front. It's rare to pop out the backside. We see that more, from a textbook standpoint, from like people that have seizure disorders where they can tense up and dislocate out the back, or if somebody gets electrocuted, that quick kind of jolt where they pop out the back. Otherwise, when people are talking about shoulder dislocations, 90% of them are popping out the front. And a lot of times you can tell. And some of it is the disuse as well, where they'll keep it at the side and they can't really move it or pick it up, even if you can't fully see abnormality at the shoulder level. Now, the caveat, and this is what I tell all of our wonderful athletic trainers as well, which are very skilled at identifying these things. If you're on a sideline, you got to make sure that you're delineating between a dislocation or a fracture, because they can certainly break up near the proximal humerus or right up by the ball and have a little bit of abnormality and not be able to lift the arm. And the last thing you want to do is be tugging on this thing trying to reduce a broken bone. And so there is a little bit of nuance in that. Sometimes the history, kind of what the mechanism was, what they were doing when they fell, can all kind of key you into that. But to your point, it's not always obvious. And that's why, I always tell people, make sure you know what you're pulling on if you're going to reduce something and try to pop a shoulder back in. But if you know it's a shoulder dislocation and you're certain of it, it's stuff we can do on the sideline or in the field and stuff like that.
All right, so it's okay to just on the sideline go, oh, your shoulder's dislocated, and just pop it back?
Oh, yeah. No, we do that multiple times during the football season. Between practice and games, we'll reduce them. We still like to get them in for x-rays and have them in a sling and they're out. It's not like we slap it back in and tell them to go back out there on the field. There's still some recovery. I think that was kind of the old school mentality on it. But you can reduce them. That's always number one, get the joint back in place. A first-time dislocation is always something where I'm of the more old-school nature, I guess, where I like to try to conservatively treat these things. Give them a chance to heal, get their full painless motion back, do some strengthening of the cuff, some stabilizing stuff with physical therapy, and then if they get their motion and strength back, let them go back and play. There's different shoulder harnesses we could use that, depending on what sport they're playing, they're very restrictive, so sometimes it's just not feasible. They can't physically play, but there are different things we could do to try to help this along. The problem is if you go back too soon, or if you have a second dislocation, especially in my under 18 population, you're up to like a 95% chance that this thing is going to come out again eventually. And so what that time frame could be, there's some kids that go back out there and within a couple weeks they pop back out. There's some that last a couple years and they come back out. But anytime you're in that second dislocation category, that's when we start talking about surgery is probably the best option for you, because the outcomes are very good with stabilization procedures that we have.
So when you do surgery, what do you do to then prevent it from coming out again? How does that work?
Yeah, so you got to think about the mechanism. When they dislocate this thing forward, again, you tear that labrum, there's some ligaments called the capsule that kind of form the joint of the shoulder get disrupted, and what you're trying to do is restore that capsule labral stability. So we're putting anchors in along the socket, we're pulling that labrum, that rim of tissue, and some of that capsule, and we're re-anchoring it back down to the front side of that socket, and basically trying to reconstitute those things, retension the shoulder. We try to roughen up the bone to get some biology in there with those anchors too, so it heals back in. But that's really what we're doing, is trying to restore, most of the time, the anterior shoulder anatomy. Now, if they're dislocating out the back or subluxing out the back, certainly you could do a posterior labral repair. It's just much more rare. In cases where, if you're thinking about the bone, not to get too far into the weeds with dislocations, but you got to think about that socket in your shoulder is pretty small. And sometimes if they pop out, they can knock off a portion of bone. So if you're looking at it as like a circle, if you're missing more than 12 to 15% of that bone is knocked off the front, sometimes you actually have to do a bony procedure where we can take bones from different parts of the body or cadaver bone and actually anchor it in there to give a little extra surface area where they lost some of that bone, because if you just did a standard soft tissue procedure with anchors, they'd have a high risk of recurrent dislocation. So it's really, there's a little bit of nuance in some of that, and it's really, that's why we get advanced imaging. We try to make sure we have all these metrics, and it's also sport dependent and how active they are. If it's somebody that was just messing around with buddies and dislocated, it's one thing. If you have a guy or a gal that's going to play collegiate sports, or he's a contact athlete, a football player, especially if he's going to continue playing through high school and into college, you really got to be thinking about the most robust procedure for them for what they're going to be doing.
So we have all kinds of sports now.
Oh yeah.
And we often think of football as the most dangerous, at least moms do. Which sports put you most at risk of having a shoulder problem?
Certainly football is one of the highest, as far as we see dislocations. But honestly, from the female side of things, gymnastics is also up there with shoulder and elbow dislocations that we'll see. It's not as common probably in football because it's not the same volume of people that are colliding against each other, but gymnasts statistically also get injured pretty close to the rate of football players. And so it's up there too, but football is number one as far as that goes. The ones that we see with dislocations in baseball are usually more like my outfielders that are running and diving for balls and landing on that outstretched arm. That's when they'll dislocate. But by and large, football is the number one.
So are there times when the injuries are so severe, or they happen so many times that, ultimately you need to give up the sport?
It's rare to get to that point, especially in the high school kids. I think that it's always a conversation, especially if somebody has had a procedure done and then they have a recurrence of, like, God forbid they dislocate again, or if they tear an ACL or something like that and have a recurrent tear. Certainly you got to think about what are your life goals, realistically, what's your ideal time frame you want to keep playing and how motivated they are. Many times, I don't think there's a hard and fast where I've ever had to tell somebody you just can't play. I like to give them the options and say, these are the risks, these are what we can do to get you back out there. And, I think it's a very patient-specific and athlete-specific conversation, but really, it's rare that I think we've ever been, hey, you can't go back out there, outside of somebody having like recurrent concussions or something like that. That's usually the kind of hard line for us. And one of my partners, who's a non-op sports guy, sees a lot of our concussions and does all the protocol management stuff on that. But those are usually, the brain trauma are the ones where we're kind of like, look, if you've had more than one concussion, it's not something that we want you to keep going back out there. Would recommend it.
We have now kids spending and adults spending so many hours on technology.
Yep.
And one of the things I know that is associated, especially with like laptop use and computers, is forward head posture, where you do like that. Does that also impact your shoulders?
It can. Certainly having a little bit of a forward roll where people get a little bit of postural issues. They call it tech neck, where they kind of lean in forward. I do think all that stuff contributes, and that's really why sometimes when people come in and you're trying to tell them about physical therapy, my first goal is, number one, get them out of pain. That's where we'll do steroid injections. That's where we'll try anti-inflammatories. If we can get them feeling better, that's a little bit easier to convince them. But to your point, bad posture, especially the people that work at computers all day, all that stuff can make you prone to developing these things over time. And so that's really what a good therapist will be doing, is breaking things down from your overall motion, the way your shoulder blade interacts with your posterior rib cage, what the strength of that rotator cuff is, any limitations in motion of the neck and shoulder, and kind of really where our posture's at. And they can stretch out the whole shoulder girdle, strengthen the posterior back, the trap, all that stuff. There's a lot of things that they can do, and that's all part of their assessment. So that's where I always like to harp and really try to, educate patients sometimes that physical therapists are not just, taking you through and saying, okay, go to this machine over here and go to this machine. I think sometimes people have the wrong idea of what can actually be achieved. And they are targeting a lot of stuff like that, especially with technology now, because a lot of people are spending a lot of time kind of hunched over a laptop or computer for hours on end each day, and that certainly can contribute to that.
Well, and you also have the repetitive motion injuries that are associated with tech use.
Oh, yeah. Yeah. I have a lot of people that, working at a desk all day will develop shoulder issues. And it's like, well, if you're constantly moving that mouse, you're constantly going back and forth all day. It doesn't have to be a strenuous job. You don't have to be, slinging bags of concrete or climbing up on a roof holding shingles to, develop shoulder pain and repetitive use injuries.
Arthritis in the shoulder, how common is that, and what does that feel like for someone experiencing it?
Yeah, absolutely. So that's kind of, one of the other things to think about with the shoulder too. Obviously, I said the rotator cuff and the biceps in my adult population are the most common. We obviously don't walk on our shoulders all day, and that's why you don't see it as much as like the hips and the knees, which are our weight-bearing joints, but we do see arthritis in the shoulder. People have been weightlifters or played sports or had prior trauma or just have bad luck, there's different times that you can develop it. So everybody that comes in for an initial evaluation, we always get screening x-rays. It's not as common, like I said, at the hips or knees, but we can certainly see it. A lot of times that's going to manifest is kind of a deeper, they'll describe it as like an ache at times, and they start losing motion where they're like, it's hard to reach around the back, pull up my pants, get my shirt on, stuff like that. So they start having limitations. It's very focal to feeling it inside versus kind of down the side of the arm, which I tend to see. And a lot of them will actually tell you about weather changes with the cold fronts and stuff coming in, just like any other joint. They'll be like, man, that cold front came in, it was really killing me. It was aching me, it was keeping up at night. And all these things kind of contribute to, arthritic signs and symptoms, but a quick x-ray, we can usually delineate that.
So you are telling me that the weather really does affect our
Yes.
aches and pains. It's not all in our heads.
No, absolutely. Cold fronts, even just kind of pressure changes, I think, can cause aches and pains when, whether it's arthritis or if somebody has a broken bone and whether or not we have to surgically fix it. I tell them for the first year or so, you're going to be as good as the weatherman sometimes when the storm fronts are coming in. And it's one of those things that's just reality. Even having shoulder surgery or any joint surgery, that first year, a lot of times they're like, man, I'm really sensitive to all that. And that's totally normal. That's something where it typically gets better with time. But if you have an arthritic joint, outside of getting it treated with like a replacement, and you can replace shoulders just like you can a hip or a knee, you may always have a little of that aches and pains with the weather changes.
So you do sports medicine primarily, but not only. Is that correct?
Yes. I mean, I still do trauma call where I'll fix broken bones, I'll fix hip fractures, all that stuff. And then in the shoulders, outside of just cuffs and everything, I do replacements. I probably do about 100 shoulder replacements a year. And that's, there's kind of two different types. There's, not getting into the weeds, anatomic and reverse, and it all depends on if you have arthritis, or sometimes people have irreparable cuff tears and they have some arthritis in there, and that's where there's a different type of replacement to address that. So there's a lot we can do, in the shoulder in particular. And so from a sports med standpoint, yes, it's kind of a very broad encompassing things, amount of procedures that we do.
Often when people need knee replacements and have knee issues, it's in both. Is that true with shoulders too, or does it tend to just be one?
Luckily, it's not always bilateral in the shoulders. Certainly, again, when people are walking on the joints, the hips and knees just get the abuse from day one. The second you start walking, you're loading those joints, and every single day for thousands of steps. So that's where the shoulders, we don't see it as common. But that being said, you can develop bilateral rotator cuff tears. You can get matching sets of arthritis. I've had many patients come in, we x-ray one shoulder, that's the one that's hurting. Well, let's shoot a quick x-ray on the other side. You have some pain. It almost looks as bad as the other one, whether or not it's symptomatic. So it certainly can be bilateral, but I don't think bilateral is as common as like the hips and the knees.
I would think too, the usage, I mean, you truly use both knees when you're
Absolutely.
walking, and if you're right-handed, then you're going to have a much more activity
100%. Yeah,
with that.
absolutely.
Okay, so final minute here, what do people need to know about coming to see you?
Yeah, absolutely. So again, we see a variety of things. You don't have to be, an athlete. You don't have to be a young person to see us. We see shoulders, knees, elbows. I got a lot of great partners too that are over there. Dr. Plancher, Dr. Barton's with us again. Then my non-op partner, Dr. Lee. All these guys are great. We're happy to get you in. Don't feel like we're going to shake your hand and sign you up for surgery. That's why I always tell everybody there's a lot of good options outside of surgery, but surgery is there if we're failing these things and it's indicated. We're happy to help you in any capacity.
All right. Thank you so much for joining us
Happy to be
today.
here.
And thank you to all of you for joining us for Healthline 3. I hope you have a good day.